Hey, curious minds, welcome to the deep dive. Today we're plunging into something that's truly, well, revolutionized modern medicine. The incredible story of antimicrobial agents. Think about it. Diseases that once decimated populations, infections that were basically a death sentence, now, thanks to these drugs, are often just a temporary inconvenience. It's a profound triumph, isn't it? But as with all great advancements, there's a critical challenge, a looming shadow. The incredible success of these drugs is constantly threatened by a relentless evolutionary adversary, the development of resistant organisms. It's an ongoing race, a never-ending battle for dominance. Our mission in this deep dive is to truly understand this intricate world, particularly focusing on those antimicrobial agents that target bacterial cell walls and membranes. We're going to extract the most important nuggets of knowledge and insight from our sources, giving you a shortcut to being truly well-informed. Our goal is to empower you to understand the intricate mechanisms, the critical clinical applications, and that ever-present, ever-evolving challenge of antibiotic resistance. Consider this your opportunity to gain mastery, to think like elite professionals in this field as we go deep into every concept.
And this isn't just theory. The insights we're pulling come directly from a foundational text in pharmacology, giving us a really solid, authoritative understanding. Understanding these drugs and the current resistance crisis isn't just for medical professionals. It's critical for anyone who interacts with healthcare, for anyone curious about the fundamental biology shaping our world. This profound challenge impacts public health, economics, and even, well, the very future of medicine itself.
Okay, let's unpack this. The major problem threatening the continued success of antimicrobial drugs is, indeed, the development of resistant organisms. Expert, what's crucial to grasp up front about this? Is it a brand new phenomenon?
That's a vital question, and the answer is no, not at all. It's important to understand that antibiotic resistance mechanisms, the very genetic and biochemical pathways that allow bacteria to shrug off our drugs, actually pre-existed the clinical use of antibiotics. They've been part of nature's microbial evolutionary toolkit for eons, long before we discovered penicillin. Think of it as a natural defense system that bacteria had, just waiting, for the right pressure to activate and proliferate.
So if the mechanisms were ancient, then our antibiotic era wasn't the start of resistance, but rather a dramatic accelerator. Is that right? How did we fuel this fire?
Absolutely. While the mechanisms were ancient, our widespread, often enthusiastic use of these powerful drugs in both human patients and significantly in animals has acted as a dramatic evolutionary catalyst. We essentially created an enormous selective pressure. Every time an antibiotic is used, it kills off the susceptible bacteria, leaving behind the resistant ones to multiply freely. This has fueled a rapid global increase in the prevalence of these drug-resistant pathogens. We've seen stark examples like the recent emergence and widespread dissemination of highly resistant gram-negative organisms. These often carry novel mechanisms of resistance, and, thanks to increased international patient travel, these dangerous strains spread with alarming speed across borders. It truly highlights the global nature of this challenge.
It sounds like misuse is a major part of this acceleration. Can you break down some of the ways we've inadvertently contributed to this problem?
Misuse is indeed a key driver. We're talking about various ways antibiotics are used inappropriately, essentially giving bacteria more opportunities to adapt. This includes administering them to patients who are unlikely to even have bacterial infections in the first place, like someone with a common cold caused by a virus. Antibiotics are useless against viruses, right? But their use still contributes to resistance in the body's normal bacteria.
Right.
Or it could be unnecessarily prolonged periods of use, far beyond what's clinically indicated. Another form of misuse is the unnecessary prescription of multiple agents, or broad-spectrum agents, when a narrower, more targeted drug would suffice. Each of these practices provides additional selection pressure, helping resistant strains gain a foothold and outcompete their susceptible counterparts.
And it's not just human medicine, right? Agriculture has also played a significant role.
That's correct, and it's a critical piece of the puzzle. Historically, agriculture used large quantities of antibiotics in livestock, not just for preventing infection, but controversially to stimulate growth. This practice contributed significantly to the selection pressure driving resistance, creating environments where resistant bacteria could thrive and potentially transfer those resistance genes to other bacteria, including those that affect humans. Thankfully, there's been a shift. Since 2017, the USA, for example, has disallowed medically important antibiotics from being used for growth promotion in livestock, a significant policy change aimed at reducing this pressure.
That's good news, at least.
It is, and globally, there are major efforts underway. Both the United Nations and the World Health Organization have launched ambitious programs specifically aimed at promoting antimicrobial stewardship and combating antibiotic resistance. It's a huge undertaking, and frankly, even if these programs achieve their goals, the benefits, the slowing or reversal of resistance trends, will take years, perhaps even decades, to become apparent. This isn't a quick fix.
What's fascinating here is just how far-reaching the ripple effects of this resistance truly are. It's not just that a drug might stop working for one person, is it?
No, it creates a cascading series of negative consequences throughout the entire healthcare system and beyond. When we encounter resistant organisms, clinicians are often forced to use antibiotics that are broader in their spectrum, meaning they kill a wider range of bacteria, including beneficial ones, disrupting the body's natural microbiome. Or we have to use drugs that are less efficacious, potentially more toxic, or certainly more expensive. This isn't just an inconvenience, it drives significant changes in how we practice medicine.
And the data really underscores the gravity of the situation. I recall seeing some pretty stark numbers from the CDC.
You're absolutely right. Infections caused by antibiotic-resistant pathogens are associated with increased costs across the board, greater morbidity, meaning more illness and suffering, and tragically, increased mortality. The Centers for Disease Control and Prevention, the CDC, estimates that every year in the United States alone, over 2.8 million people acquire infections due to resistant bacteria, and a staggering 35,000 people die from them.
Wow.
Yeah, that's a massive public health burden, a silent epidemic running alongside others.
It sounds like we're in a tough spot with new drug development. Is innovation keeping pace with this evolving threat?
Unfortunately, no. Compounding this challenge is a critical innovation lag. As the need for new and effective antibiotics has grown in recent years, the development of truly novel agents has not kept pace. While we have seen a number of new antimicrobial agents approved in the last decade, the reality is that most of them are quite similar to older drugs. They might be variations on a theme, offering incremental improvements rather than entirely new compounds with novel mechanisms of action that bacteria haven't seen before. This means that, pending the identification and development of genuinely new targets and compounds, we'll have to heavily rely on our currently available families of drugs. In the face of this ongoing, relentless development of resistance, considerable sustained effort will be required to simply maintain the effectiveness of these existing drug groups. It's a constant arms race, and right now, the bacteria might have a slight lead in certain areas.
So when our sources refer to drugs that are effective against susceptible organisms, what does that truly mean for someone who wants to master this field? It sounds like a critical distinction.
It is, and it's a very precise and important distinction for an elite professional to grasp. It means that within a specified bacterial species, some strains have already acquired resistance to a particular drug, but other strains within that same species have not yet developed resistance. These are the ones that remain susceptible to the drug. This is why, especially in serious infections or when you have a patient who is very ill, susceptibility testing, often called culture and sensitivity testing, is absolutely critical. It helps us determine which specific drug will be effective against the particular strain of bacteria causing that patient's infection, rather than just guessing. It moves us from broad empiric therapy to targeted, effective treatment, and helps preserve the utility of our existing drugs by not overusing them when they won't work, which just drives more resistance. This precision is vital for effective patient care and for stewardship.
Here's where it gets really interesting. Let's dive into the core players in this fight, starting with the Beta-Lactam compounds. This is a huge foundational class of antibiotics. We're talking about penicillins, cephalosporins, monobactams, and carbapenems, along with their strategic partners, the lactamase inhibitors. Expert, what ties them all together? What's their shared identity that makes them a family?
What defines them, their common identity, is that distinctive four-membered lactam ring in their chemical structure. This ring isn't just a pretty shape, it's absolutely central to their function. It's the key part that interacts with the bacterial machinery, and when bacteria learn to break that ring, well, the drug becomes useless.
Let's zoom in on the pioneers, the penicillins. Can you give us a simplified look at their chemistry and how their structure is so vital for their action?
Think of a penicillin as having a core blueprint. A thiazolidine ring, let's call it ring A, connected to that crucial lactam ring, ring B. Then Off ring B, there's a side chain, an R group, which is what we can modify to create different types of penicillins, each with unique characteristics. The critical point for mastery here is that the structural integrity of this entire core, this 6-amino penicillinic acid nucleus rings A and B together, is absolutely essential for the drug to work. If bacteria hydrolyze or break open that wall-lactam ring with their lactamase enzymes, the drug is instantly converted into penicilloic acid, which is completely inactive. It's like breaking the key so it can no longer fit the lock.
And how do we classify these early pioneers? What problems were they designed to solve?
We classify penicillins based on their properties and what they were developed to combat. First, you have the original penicillins, like penicillin G. These were groundbreaking. They had their greatest activity against gram-positive organisms like streptococci, some gram-negative cocci, and certain non-lactamase-producing anaerobes. But they had limitations. Little activity against gram-negative rods, and crucially, they were highly susceptible to those bacterial lactamases we just talked about. This led to resistance challenges almost immediately.
Right. So bacteria fought back fast.
They did. So we adapted. The next generation were the anti-staphylococcal penicillins, like nafcillin, oxacillin, and dicloxacillin. Their key feature, and why they were developed, was their resistance to staphylococcal lactamases, a huge leap forward for fighting Staphylococcus aureus. They're active against Staphylococcus and streptococci, but notably not against enterococci or most gram-negative bacteria. A quick historical note for professionals: methicillin, the very first of this group, is no longer used clinically due to significant adverse effects, particularly kidney inflammation. Then came the extended spectrum penicillins, which include their aminopenicillins like ampicillin and amoxicillin, and the anti-pseudomonal penicillins like piperacillin. These drugs cleverly retain the core penicillin spectrum, but extend their reach to include more gram-negative rods. They do this because they have an enhanced ability to penetrate the gram-negative outer membrane, a key barrier. However, despite their broader reach, they are still relatively susceptible to hydrolysis by many whole lactamases, meaning bacteria can still find ways to disarm them. It's a constant push and pull.
That's a clear evolution. And when we think about how these drugs are measured and given to patients, what are the important nuances?
Well, historically, penicillin G activity was defined in units. 1 million units equals about 0.6 grams. Nowadays, most semi-synthetic penicillins are prescribed by weight. When we assess effectiveness, we talk about the minimum inhibitory concentration, or MIC, in micrograms per milliliter, the lowest concentration that stops bacterial growth. Most penicillins are formulated as sodium or potassium salts. For example, 1 million units of potassium penicillin G contains about 1.7 million DThu of potassium, a detail important for patients with electrolyte imbalances. And for intramuscular injections, we developed repository forms like procaine and benzothine salts of penicillin G. These are brilliant for prolonged effect. They're designed for delayed absorption, which leads to sustained concentrations in the blood and tissues. For instance, a single IM injection of 1.2 million units of benzothine penicillin can maintain serum levels sufficient for treating beta-hemolytic streptococcal infections for up to 10 days and even prevent reinfection for 3 weeks. A smaller dose of procaine penicillin, 600,000 units, gives you a peak for about 12-24 hours. As for stability, dry crystalline forms are stable for years when refrigerated, but once in solution, they rapidly lose activity, typically within 24 hours, so they need to be prepared fresh. This affects how we store and administer them in a hospital setting.
Now let's get into the heart of how these drugs actually work, their mechanism of action. This is where their brilliance truly lies. Can you walk us through the how?
Absolutely. Think of the bacterial cell wall as a tiny but mighty fortress, a rigid outer layer that maintains cell integrity and prevents the bacterium from bursting due to high internal osmotic pressure. This fortress is built from a complex cross-linked polymer called peptidoglycan. Imagine it as a brick wall.
Okay.
The bricks are alternating amino sugars, N-acetylglucosamine and N-acetylmuramic acid. And attached to each N-acetylmuramic acid brick is a 5-amino acid peptide chain, crucially ending in a D-alanine sequence. Now, bacteria have their own construction workers, enzymes called penicillin-binding proteins, or PBPs. These PBPs are transpeptidases that normally remove that terminal alanine to form crosslinks, literally linking the bricks together, giving the cell wall its essential strength and rigidity.
So the beta-lactams are like cleverly designed imposter bricks.
Exactly. Here's the aha moment. Beta-lactam antibiotics are ingenious structural analogs of that natural dalbavancin building block. Because they mimic this crucial part, they can covalently bind to the active site of these PBPs, essentially jamming the construction worker. This binding inhibits the transpeptidation reaction, effectively halting the synthesis of new peptidoglycan and critically leading to the death of the bacterial cell. While the exact mechanism of cell death isn't completely understood, enzymes within the bacteria itself, called autolysins, which normally remodel the cell wall, are also involved, contributing to the cell's demise once its structural integrity is compromised. A critical detail for mastery. Beta-lactam antibiotics only kill bacterial cells when they're actively growing and synthesizing their cell wall. If the bacteria are dormant, these drugs won't work effectively. This is why timing and bacterial growth phase are important considerations in treatment.
That's a fantastic explanation of their ingenuity. But as we know, bacteria master adapters. So let's talk about their countermoves. Resistance. What are the main ways bacteria fight back?
When it comes to resistance to penicillins and other lactams, there are 4 primary strategies bacteria employ. The first, and most common, is the inactivation of the antibiotic by beta-lactamase. Imagine bacteria developing an enzyme that acts like a pair of molecular scissors, specifically designed to cut and disable the bactam ring, rendering the antibiotic useless. Hundreds of different beta-lactamases have been identified.
Hundreds, wow.
Yeah. Some have a narrow substrate specificity, like those found in Staphylococcus aureus or E. coli, which primarily target penicillins. But then you have the broader or extended spectrum lactamases, ESBLs, produced by organisms like Pseudomonas aeruginosa and Enterobacterales. These are far more dangerous because they can hydrolyze both cephalosporins and penicillins, posing a much wider threat. Even our big guns, the carbapenems, aren't completely immune. They can be hydrolyzed by metallo-lactamases and other carbapenemases. It's an ongoing biochemical arms race.
So that's one way they disarm the drug. What's the second?
The second major mechanism is the modification of their target PBPs, those penicillin binding proteins we just discussed. Instead of breaking down the drug, the bacteria modify the drug's target site. This is the basis of methicillin resistance in Staphylococci, giving us MRSA, and also penicillin resistance in pneumococci and most resistant enterococci. What happens is these resistant organisms produce PBPs that simply have a low affinity for binding beta-lactam antibiotics. It's like the lock has changed its shape just enough so the key no longer fits well. This means they are not inhibited except at very high drug concentrations, which are often clinically unachievable in a patient without causing unacceptable toxicity.
Fascinating. And the third line of defense?
Third, we have impaired penetration of the drug to its target PBPs. This mechanism occurs only in gram-negative species because of their unique, impermeable outer membrane, a formidable barrier absent in gram-positive bacteria. All lactam antibiotics normally cross this outer membrane and enter gram-negative organisms via specific outer membrane protein channels called porins. If these porin channels are absent or their production is downregulated, essentially closing the entry gates, it can significantly impair drug entry into the bacterial cell.
So it's harder for the drug to even get inside.
Exactly. While poor penetration alone usually isn't enough to confer full resistance because enough antibiotic eventually gets in, this barrier becomes critically important if it's combined with a beta-lactamase. In such cases, the beta-lactamase can hydrolyze the drug faster than it can even enter the cell, effectively disarming it before it reaches its target inside. It's a combination punch.
And finally, the fourth mechanism.
Finally, the fourth mechanism is antibiotic efflux. Again, this is typically seen in gram-negative organisms. They may produce efflux pumps, which are complex systems with cytoplasmic and periplasmic protein components that act like efficient little pumps. These pumps actively transport some beta-lactam antibiotics from the periplasm, the space between the outer and inner membranes, back across a cell wall, outer membrane. Essentially, the bacterium is actively kicking the drug out before it can do its job. It's like a tiny bouncer at the cellular level.
That paints a comprehensive picture of the bacterial arsenal. Now, once these drugs are in the body, how do they move through it? Let's talk about pharmacokinetics.
Pharmacokinetics, or how the body handles these drugs, is critical for understanding their clinical utility. For orally administered penicillins, absorption varies greatly, influenced by acid stability and protein binding. For instance, nafcillin has erratic oral absorption, making it unreliable for oral use. However, dicloxacillin, ampicillin, and amoxicillin are acid stable and relatively well absorbed. A 500 milligram oral dose can produce serum concentrations of 4 to 8 milligml. A key point for optimal absorption for most oral penicillins, except amoxicillin, is that food impairs their absorption. So they should be administered at least 1 to 2 hours before or after a meal. Amoxicillin is a convenient exception. It can be taken with food.
Okay, that's useful to know.
Definitely. When it comes to administration routes, intravenous administration of penicillin G is generally preferred over intramuscular IM, mainly because large IM doses can be quite irritating and locally painful. A 1-gram IV injection of penicillin G, about 1.6 million units, can lead to serum concentrations of 2050 millicg/ml within 30 minutes. It's important to remember that only the free or unbound drug is active. Highly protein-bound penicillins, like nafcillin, generally achieve lower free drug concentrations in the serum compared to less protein-bound ones, such as penicillin G or ampicillin, which can impact efficacy.
Right, the binding matters.
It does. In terms of distribution, penicillins generally spread widely throughout body fluids and tissues. However, being polar molecules, their concentrations inside cells are typically lower than in extracellular fluids. Penetration into certain sanctuaries like the eye, prostate, and the central nervous system, CNS, is usually poor. But here's an important clinical exception. With active inflammation of the meninges, as seen in bacterial meningitis, penicillin concentrations of 1 to 5 millicg/ml can be achieved in the CNS if a daily parenteral dose of 18-24 million units is administered. These concentrations are sufficient to kill susceptible strains of pneumococci and meningococci, which is clinically vital for treating life-threatening infections.
So inflammation actually helps the drug get where it needs to go in that case.
Precisely. Penicillins are rapidly excreted by the kidneys, with tubular secretion accounting for about 90% of renal excretion and glomerular filtration for the remaining 10%. Penicillin G has a normal half-life of approximately 30 minutes, but in cases of severe renal failure, this can be prolonged to as much as 10 hours, necessitating dose adjustments. Ampicillin and the extended-spectrum penicillins are secreted more slowly, with half-lives around 1 hour. For penicillins primarily cleared by the kidney, the dose must be carefully adjusted based on renal function, for instance. If creatinine clearance is 10 mmol or less, approximately 1/4 to 1/3 of the normal dose is typically administered.
So kidney function is critical.
Very much so. Interestingly, nafcillin is primarily cleared by biliary excretion, and oxacillin, dicloxacillin, and cloxacillin are eliminated by both the kidney and biliary excretion, meaning no dosage adjustment is typically required for these specific drugs in patients with renal failure. And a final point on pharmacokinetics. In newborns, penicillin clearance is less efficient, so weight-adjusted doses can result in higher and more prolonged systemic concentrations than in adults, requiring careful monitoring.
That's a deep dive into how our bodies handle these drugs. Now let's turn this knowledge into practical understanding. What are the key clinical uses? Who gets what and why?
For oral penicillins, remember the general rule. With the exception of amoxicillin, administer them 1 to 2 hours before or after a meal to optimize absorption. A crucial point for an elite professional. Blood levels of all penicillins can be increased by the simultaneous administration of probenecid, typically 0.5 grams every 6 hours orally in adults. Probenecid works by impairing the renal tubular secretion of weak acids like Beta-Lactam compounds, effectively keeping the antibiotic in the body longer.
Like a booster.
Kind of, yeah. And a critical caution worth repeating. Penicillins, like all antibacterial antibiotics, should never be used for viral infections. They should only be prescribed when there is a reasonable suspicion of or documented infection with susceptible organisms. This is foundational to combating resistance.
Absolutely.
Let's look at specific penicillin uses. Penicillin G remains a drug of choice for infections caused by streptococci, meningococci, some enterococci, penicillin-susceptible pneumococci, and non-lactamase-producing staphylococci. It's also vital for Treponema pallidum, the cause of syphilis, and certain other spirochetes, some Clostridium species, actinomyces, other gram-positive rods, and non-lactamase-producing gram-negative anaerobic organisms. Dosing typically ranges from 4 to 24 million units per day intravenously in 4 to 6 divided doses, or it can be given as a continuous intravenous infusion for very high doses, especially in serious infections.
Okay, what if the oral version, penicillin V?
Penicillin V, the oral form, is indicated only for minor infections. This is due to its relatively poor bioavailability, the need for dosing 4 times a day, and its narrow antibacterial spectrum. Amoxicillin is now often preferred over it for oral use. For intramuscular injections, benzathine penicillin and procaine penicillin G are used for prolonged drug levels. A single 1.2 million units of benzathine penicillin is highly effective for vancomycin streptococcal pharyngitis, and given intramuscularly every 3-4 weeks, it can prevent reinfection in patients with rheumatic fever. For syphilis, benzathine penicillin G, 2.4 million units intramuscularly once a week for 1-3 weeks is the standard effective treatment. Procaine penicillin G was once used for pneumococcal pneumonia and gonorrhea, but it's rarely used now due to widespread resistance in gonococcal strains and many pneumococci.
Got it. and the ones designed to beat staph defenses.
Right, the penicillins resistant to staphylococcal beta-lactamase, like nafcillin and oxacillin. These semisynthetic penicillins are indicated for infections caused by moolactamase-producing staphylococci. Susceptible strains of streptococci and pneumococci are also susceptible to these. However, they are not effective against Listeria monocytogenes and Irocococci or methicillin-resistant strains of staphylococci like MRSA. While the empiric use of these drugs has decreased due to rising MRSA rates, they remain the drug of choice for infections caused by methicillin-susceptible and penicillin-resistant strains of staphylococci. For mild to moderate localized staphylococcal infections, dicloxacillin is suitable, typically 0.25 to 0.5 grams orally every 4 to 6 hours for adults, or 25 to 100 kilograms for children. They are acid stable and have reasonable bioavailability, but remember, food interferes with absorption.
Okay.
For serious staphylococcal infections, such as endocarditis, oxacillin and nafcillin are considered drugs of choice, usually given intravenously at 8-12 grams per day, divided into 1 to 2 gram doses every 4 to 6 hours, or 50 to 200 kilograms for children.
And the extended spectrum ones, how are they used?
Next, the extended spectrum penicillins. This group, including aminopenicillins, carboxypenicillins, and uridopenicillins, has greater activity against gram-negative bacteria because of their enhanced ability to penetrate the gram-negative outer membrane. However, like penicillin G, many are still inactivated by many lactamases. The aminopenicillins, ampicillin, and amoxicillin have very similar spectrums, but amoxicillin is notably better absorbed orally, making it a common choice for outpatient settings.
Right, amoxicillin is very common.
It is. Amoxicillin, typically 250 to 500 milligrams 3 times daily, is roughly equivalent to ampicillin given 4 times daily, and is commonly used orally for otitis and lower respiratory tract infections. Both ampicillin and amoxicillin are the most active oral lactam antibiotics against pneumococci, with elevated MICs to penicillin, making them preferred for treating infections caused by these strains. Ampicillin is effective against susceptible Shigella species, though amoxicillin appears less so. For serious infections, ampicillin is useful at dosages of 4-12 grams per day intravenously against susceptible organisms, including anaerobes, enterococci, Listeria monocytogenes, and balactamase-negative strains of gram-negative cocci and bacilli, like E. coli and Salmonella species. While non-lactamase-producing H. influenza are generally susceptible, altered PVP strains are an emerging concern.
But resistance is still a problem for ampicillin.
Oh, yes. A crucial limitation for ampicillin due to resistance. It can no longer be used for empiric therapy of urinary tract infections or typhoid fever because gram-negative bacilli now widely produce archlatomases that inactivate it. Furthermore, ampicillin is not active against Klebsiella species, Enterobacter species, Pseudomonas aeruginosa, Citrobacter species, Serratia marcescens, indole-positive Proteus species, and other gram-negative aerobes commonly encountered in hospital-acquired infections. These organisms intrinsically produce archlotactamases that inactivate ampicillin, making these drugs ineffective without careful susceptibility testing.
So careful selection is key.
Absolutely. While the carboxypenicillins, carbonicillin and ticarcillin, were developed to broaden the spectrum against gram-negative pathogens, including Pseudomonas aeruginosa, neither is available in the USA anymore. The uridopenicillin, piperacillin, is active against many gram-negative bacilli, such as Klebsiella pneumonia and Pseudomonas aeruginosa. Currently, piperacillin is only available as a co-formulation with the lactamase inhibitor tazobactam. Due to Pseudomonas aeruginosa's tendency to develop resistance during therapy, there's been interest in combining an anti-pseudomonal lactam with an aminoglycoside or fluoroquinolone, especially for infections outside the urinary tract. However, most clinical data often don't support combination therapy over single drug therapy once cultures and susceptibilities are known, so targeted therapy is always best once information is available.
Which brings us to those combinations.
Right.
Exactly. Lastly, within penicillins, we have penicillins combined with beta-lactamase inhibitors. Ampicillin, amoxicillin, and piperacillin are available in combination with inhibitors like sulbactam, clavulanic acid, or tazobactam. The key benefit here is that adding a lactamase inhibitor extends the activity of these penicillins to include lactamase-producing strains of S. aureus, as well as some lactamase-producing gram-negative bacteria. This allows these older drugs to regain effectiveness against bacteria that would otherwise be resistant, greatly enhancing our treatment options.
That's a deep dive into the penicillins. But of course, even these powerful drugs have side effects. What are the key adverse reactions we need to be aware of?
Penicillins are generally well tolerated, which ironically can encourage their inappropriate use, a major driver of resistance. Most of the serious adverse effects are due to hypersensitivity reactions. The substances that trigger the allergic response are typically degradation products of penicillins, particularly penicilloic acid, which bind to host proteins.
So it's the breakdown products causing the allergy.
Often, yes. A patient's self-reported history of a penicillin allergy can often be unreliable. About 5–8% of people report a penicillin allergy, but only a small number of those will actually have a serious reaction if given penicillin. In fact, less than 1% of people who previously received penicillin without any incident will have an allergic reaction if given it again.
Interesting.
However, because of the potential for anaphylaxis, a very rare but severe allergic reaction occurring in about 0.05% of recipients, penicillin should always be administered with caution or a substitute drug considered if the person has a history of serious penicillin allergy. Penicillin skin testing can also be used to evaluate hypersensitivity, and if the skin test is negative, most patients can safely receive penicillin.
Okay. What other reactions can happen?
Other allergic reactions include serum sickness type reactions, which are now rare. These involve hives, fever, joint swelling, angioedema, pruritus, itching, and respiratory compromise, typically occurring 7–12 days after exposure. Various other skin rashes can also occur. Beyond rashes, patients might experience oral lesions, fever, interstitial nephritis, which is an autoimmune reaction to a penicillin protein complex, eosinophilia, hemolytic anemia, other hematologic disturbances, and vasculitis. While most patients allergic to penicillins can be treated with alternative drugs if it's absolutely necessary, for instance in severe infections like enterococcal endocarditis or norosyphilis, desensitization can be accomplished by giving gradually increasing doses of penicillin to patients with type I hypersensitivity under very controlled conditions.
And specific drug toxicities.
There are also some specific toxicities. In patients with renal failure, high doses of penicillin can lead to seizures. Nafcillin is specifically associated with neutropenia, which is a decrease in white blood cells, and interstitial nephritis. Oxacillin can cause hepatitis. Methicillin, the first anti-staphylococcal penicillin, was commonly associated with interstitial nephritis, which is one of the main reasons it's no longer used clinically. Large oral doses of penicillins can lead to gastrointestinal upset, particularly nausea, vomiting, and diarrhea. Importantly, penicillins, along with many other antibiotics, are associated with the development of colitis caused by Clostridioides difficile infection, a serious gut infection.
TF.
Exactly. Secondary candidal infections, like thrush in the oropharynx or vaginal yeast infections, may also occur due to disruption of normal flora. Ampicillin and amoxicillin can be associated with skin rashes when prescribed in the setting of viral illnesses, particularly during acute Epstein-Barr virus infection, though the incidence of rash might be lower than initially reported. And finally, a specific combination to be aware of for professionals. Piperacillin tazobactam, when combined with vancomycin, has been associated with a greater incidence of acute kidney injury compared to other lactam agents combined with vancomycin. This highlights the importance of carefully considering drug interactions.
That's an exhaustive overview of penicillins. Expert, I'm curious, how does all this detail translate into a real-world clinical scenario? Could you walk us through how a doctor might think about prescribing these drugs, especially when dealing with the kind of resistance and allergy concerns we've talked about?
Great question, host. Let's take that case study we mentioned earlier. The 45-year-old man presenting with pneumonia and confusion, requiring empiric antibiotics for both pneumonia and meningitis, with a history of an amoxicillin rash. The solution prescribed here is an intravenous third-generation cephalosporin, specifically ceftriaxone or cefotaxime. The rationale is quite clear and a good example of clinical decision-making. These drugs offer adequate penetration into inflamed meninges, which is crucial for treating meningitis. They are also active against the common bacteria that cause community-acquired pneumonia and meningitis in middle-aged adults, such as pneumococcus and meningococcus.
That makes sense. And the vancomycin part?
To provide a safety net, vancomycin is also administered initially, before culture and sensitivity results are back. This acts as a safeguard in case the patient is infected with the penicillin-resistant pneumococcus, as vancomycin is a go-to drug for such scenarios, especially when resistance levels are high. Regarding the amoxicillin rash, while it's noted in the patient's history, in a life-threatening illness like this, it's unlikely to significantly affect the choice of a third-generation cephalosporin. This is because aminopenicillin rashes are often not a true type I hypersensitivity reaction, and the cross-reactivity with third-generation cephalosporins is quite low, less than 1%. So, the benefit of rapid, effective treatment outweighs the minimal theoretical risk of cross-reaction in this urgent, life-threatening situation. This is a common scenario where balancing risk and benefit is paramount.
We've explored the penicillin story, the triumphs and the challenges, but penicillin was just the beginning for beta-lactams. Expert, what came next in our arsenal? How did we refine this chemical secret weapon to create something even more versatile?
That brings us to the cephalosporins. These drugs are structurally similar to penicillins, but they offer a significant advantage that broadened our horizons. They are generally more stable to many bacterial lactamases. This enhanced stability is what gives them a broader spectrum of activity, allowing us to hit more types of bacteria. However, there's a growing concern. Strains of E. coli and Klebsiella species that express extended-spectrum lactamases or ESBLs can still hydrolyze most cephalosporins, diminishing their effectiveness. Also, it's important to note for precision that cephalosporins are generally not active against Listeria monocytogenes, and among all the available cephalosporins, only ceftaroline has some activity against Enterococci when given as a single drug.
I understand they're classified into generations. Can you explain this generational concept and what it signifies for their activity?
Indeed. The nucleus of cephalosporins is 7-aminocephalosporanic acid, which closely resembles the 6-aminopenicillinic acid nucleus of penicillins. While natural cephalosporins have low antimicrobial activity, scientists have skillfully attached various R1 and R2 groups to this nucleus, creating hundreds of potent compounds, many with low toxicity. We classify them into generations, traditionally 4 major groups based primarily on their evolving spectrum of antimicrobial activity and their resistance to lactamases. Each generation represents an advance or a shift in focus against different bacterial threats. However, some newer drugs don't always fit neatly into these traditional categories, reflecting the complexity of modern drug development.
Okay, let's start with generation 1.
Let's start with the first-generation cephalosporins, which include cefazolin and cephalexin in the USA. These drugs are very active against gram-positive cocci, like streptococci and staphylococci. It's important to remember that traditional cephalosporins are not active against methicillin-resistant strains of staphylococci. New compounds, like ceftaroline, are exceptions developed specifically to address that. These older agents are often sensitive for E. coli, K. pneumonia, and Proteus mirabilis. However, their activity against formidable gram-negative pathogens like Pseudomonas aeruginosa, indel-positive Proteus species, Enterobacter species, Serratia marcescens, Citrobacter species, and a Cinetobacter species is cool. Gram-positive anaerobic cocci are usually sensitive, but Bacteroides fragilis is not reliably susceptible.
How are they given and handled by the body?
For their pharmacokinetics and dosage, cephalexin is the widely used oral first-generation agent. After oral 500 milligram doses, peak serum levels are around 15-20 millicg/ml. They achieve very high urine concentrations, making them excellent for urinary tract infections, but levels in most other tissues are variable and generally lower than in serum. Cephalexin is typically given orally at 0.25-0.5 grams 4 times daily for adults, or 25-100 milligram/kilogram for children. Excretion is mainly by glomerular filtration and tubular secretion into the urine. Drugs like probenecid, which block tubular secretion, can significantly increase serum levels, a useful trick in some clinical scenarios.
Wait, with penicillins?
Exactly. In patients with impaired renal function, the dosage must be reduced proportionally. For parenteral administration, cefazolin is the only first-generation cephalosporin still in general use. An intravenous infusion of 1 gram yields a peak level of approximately 185 milligml. The usual adult intravenous dosage is 0.52 grams every 8 hours, and it can also be given intramuscularly, though it can be painful. Like cephalexin, efazolin is excreted via the kidney, requiring dose adjustments for impaired renal function.
And where do we use these first-gen drugs?
In terms of clinical uses, oral first-generation cephalosporins are useful for urinary tract infections and skin soft tissue infections caused by susceptible staphylococci or streptococci, including cellulitis or soft tissue abscesses. However, they should not be relied upon for serious systemic infections. Cefazolin, being a parenteral drug, penetrates well into most tissues. It is a drug of choice for surgical prophylaxis, preventing infections after surgery, and for many streptococcal and staphylococcal infections requiring intravenous therapy. It can be used for infections due to E. coli or K. pneumonia if the organism is documented to be susceptible. Critically, cefazolin does not penetrate the central nervous system, so it cannot be used to treat meningitis.
That's crucial.
Absolutely. It's often better tolerated than anti-staphylococcal penicillins and has been shown to be effective for serious staphylococcal infections like bacteremia. It can also be used in patients with mild penicillin allergy, specifically those without a history of immediate hypersensitivity, offering an important alternative.
So if first-generation drugs target some gram-positives and basic gram-negatives, what did the second-generation cephalosporins add to our arsenal?
The second-generation cephalosporins are a more heterogeneous group, including cefaclor, cefuroxime, and cefprozil in the USA, along with cefoxitin and cefotitin, which are structurally related cephomycins with crucial activity against anaerobes. There are notable differences in their individual activity, pharmacokinetics, and toxicity. Generally, they're active against organisms inhibited by first-generation drugs, but they boast extended gram-negative coverage. Klebsiella species, including some resistant to first-generation cephalosporins, are usually sensitive. For specific activities, cefuroxime and cefaclor are active against H. influenza, but not against Serratia or Bacteroides fragilis. In contrast, cefoxitin and cefotitin are active against B. fragilis and some Serratia strains, but they are less active against H. influenza. Like first-generation agents, no member of this group is active against Enterococci or Pseudomonas aeruginosa. Compared with other cephalosporins, cefoxitin shows improved stability in the presence of extended-spectrum lactamases produced by E. coli and Klebsiella species, and while clinical data is limited, it might offer an alternative to carbapenems for treating certain infections caused by these organisms. A key warning for advanced understanding. While second-generation cephalosporins might show in vitro activity against Enterobacter species, resistant mutants that express a chromosomal lactamase, which hydrolyzes these compounds, and third-generation cephalosporins are readily selected. This inducible resistance means the drug can stop working during treatment, so these drugs should not be used to treat Enterobacter infections, even if lab tests initially show susceptibility.
That's a really important caveat. How are these second-gen drugs typically dosed?
For their pharmacokinetics and dosage, cefuroxime is a commonly used oral agent, typically 250-500 mg orally twice daily for adults, or 20-40 mg for children, up to 1 gram daily. These drugs are not predictably active against penicillin non-susceptible pneumococci. For parenteral administration, a 1-gram intravenous infusion of most second-generation cephalosporins results in serum levels of 75-125 millisiegeml. Intramuscular administration is often painful and should be avoided. Doses and dosing intervals vary by agent, but all are renally cleared and require dosage adjustment in renal failure.
And their main uses?
In terms of their clinical uses, the oral second-generation cephalosporins are active against beta-lactamase-producing H. influenza, or Moraxella catarrhalis, making them primary choices for treating sinusitis, otitis, and lower respiratory tract infections. Because of their activity against anaerobes, including many B. fragilis strains, cefoxitin and cefotitin can be used to treat mixed anaerobic infections such as peritonitis, diverticulitis, and pelvic inflammatory disease. Cefuroxime is sometimes used for community-acquired pneumonia due to its activity against beta-lactamase-producing H. influenza and many pneumococci. Although cefuroxime does cross the blood-brain barrier, it is less effective than ceftriaxone or cefotaxime for treating meningitis and should not be used for that indication.
So what about the next generation? What new frontiers do they conquer? Let's talk about third-generation cephalosporins. What was the leap here?
The leap was significant. These drugs have expanded gram-negative coverage compared to second-generation agents, and crucially, some were able to cross the blood-brain barrier, making them vital for CNS infections like meningitis.
Okay. CNS penetration is key.
Very key. They may be active against Citrobacter, Serratia marcescens, and Providencia. They are also effective against lactamase-producing strains of Haemophilus and Neisseria. A key distinction here is ceftazidime. It is the only agent in this generation with useful activity against Pseudomonas aeruginosa, a notoriously difficult-to-treat pathogen. However, like the second-generation drugs, third-generation cephalosporins are hydrolyzed by beta-lactamase, and they are not reliably active against Enterobacter species, which commonly have inducible beta-lactamase production, as we discussed. This means resistance can emerge during treatment.
So that Enterobacter problem persists.
It does. Serratia, Providencia, Acinetobacter, and Citrobacter also produce a chromosomally encoded cephalosporinase that, when constitutively expressed, can confer resistance to third-generation cephalosporins. Among the oral agents in this group, like cefixime, cefdinir, ceftibutin, and cefodoxime proxetil, they generally have similar activity, except that cefixime and ceftibutin are much less active against pneumococci and have poor activity against S. aureus.
How do these third-gen drugs behave in the body?
For their pharmacokinetics and dosage, intravenous infusion of 1 gram of a parenteral third-generation cephalosporin typically produces serum levels of 60-140 mg/ml. These drugs penetrate body fluids and tissues well, and when administered intravenously, they achieve levels in the cerebrospinal fluids sufficient to inhibit most susceptible pathogens, which is critical for meningitis treatment. Their half-lives and the necessary dosing intervals vary greatly. Ceftriaxone, for example, has a relatively long half-life of 7-8 hours, allowing it to be injected once every 24 hours at a dosage of 1550 milligram per day.
Once a day is convenient?
Vary. A single daily 1-gram dose is often sufficient for most serious infections, although 2 grams every 12 hours is recommended for treating meningitis and 2 grams every 24 hours for endocarditis or osteomyelitis. The other drugs in this group have shorter half-lives, typically 1 to 1.7 hours, and are infused every 6 to 8 hours in dosages between 2 and 12 grams per day, depending on the severity of the infection. For oral agents, Cefixime can be given orally at 200 milligrams twice daily or 400 milligrams once daily for urinary tract infections. Due to increasing resistance, Cefixime is no longer recommended for uncomplicated gonococcal urethritis and cervicitis. Instead, intramuscular ceftriaxone is now the regimen of choice for treating gonococcal infections.
Good to know that shift.
Yes. Adult doses for cefpodox and Proxetil are 200 and 400 milligrams twice daily, for ceftabutin, 400 milligrams once daily, and for ceftonir, 300 milligrams every 12 hours. In terms of excretion, ceftriaxone is primarily cleared through the biliary tract, meaning no dosage adjustment is required for renal impairment. However, the other third-generation cephalosporins are excreted by the kidney and therefore require dosage adjustment in patients with renal insufficiency.
And their clinical sweet spots.
In terms of clinical uses, third-generation cephalosporins are employed to treat a wide variety of serious infections caused by organisms that are often resistant to many other drugs. However, it's important to note that strains expressing extended-spectrum lactamases, ESBLs, are not susceptible to these drugs. Furthermore, third-generation cephalosporins should be avoided in the treatment of Enterobacter infections, even if the clinical isolate appears susceptible in vitro, because of the high risk of resistance emergence during therapy due to inducible beta-lactamase production.
Right, that warning again.
It's critical. Ceftriaxone and cefotaxime are specifically approved for the treatment of meningitis, including those caused by pneumococci, meningococci, H. influenza, and susceptible enteric gram-negative rods, though not Listeria monocytogenes. They are also the most active cephalosporins against penicillin non-susceptible strains of pneumococci and are recommended for empiric therapy of serious infections that may be caused by these strains. For meningitis caused by pneumococci with penicillin MICs greater than 1 millicg/ml, even these agents may not be sufficient, and the addition of vancomycin is recommended as a crucial safeguard. Other potential indications include empiric therapy for sepsis in both immunocompetent and immunocompromised patients, and treating infections where a cephalosporin is the least toxic drug available.
It sounds like each generation is an arms race response. So what about the fourth-generation cephalosporins? What was the specific bacterial threat they were designed to counter?
You're exactly right. It's an ongoing response. Currently, cefepime is the only available fourth-generation drug in the USA. Its key feature is that it is more resistant to hydrolysis by chromosomal beta-lactamases, particularly those produced by tricky bugs like Enterobacter.
Ah, tackling the Enterobacter issue more directly.
Exactly. This was a significant advance because it tackles that inducible resistance we discussed. However, like the third-generation compounds, it is still hydrolyzed by extended-spectrum lactamases, ESBLs. Cefepime boasts good activity against Pseudomonas aeruginosa, Enterobacterales, methicillin-susceptible Staphylococcus aureus, MSSA, and Streptococcus pneumonia. It is also highly active against Haemophilus and Neisseria species. Pharmacokinetically, it penetrates well into the cerebrospinal fluid, is cleared by the kidneys, and has a half-life of 2 hours, making its properties very similar to ceftazidime. But unlike ceftazidime, cefepime has good activity against most penicillin non-susceptible strains of Streptococci, and it is particularly useful in the treatment of Enterobacter infections, where other cephalosporins would fail due to resistance emergence.
How is it dosed?
The standard dose for cefepime is 1 to 2 grams infused every 12 hours. However, for more complicated infections caused by Pseudomonas aeruginosa or in immunocompromised patients, doses are typically increased to 2 grams every 8 hours. Because of its broad-spectrum activity, cefepime is commonly used empirically in patients presenting with febrile neutropenia, often in combination with other agents, as it provides a robust initial broad coverage.
Now, for something truly novel, a cephalosporin that takes on MRSA, ceftaroline fosamil sounds like a game changer. How does it work against such a formidable foe?
Ceftaroline fosamil, which is a prodrug of the active metabolite ceftaroline, is indeed revolutionary. It's the first beta-lactam antibiotic approved in the USA with activity against methicillin-resistant Staphylococcus, MRSA. Its mechanism is quite clever. It has increased binding to penicillin-binding protein 2A, PBP2A, which is the very protein that mediates methicillin resistance in Staphylococcus. By strongly binding to this altered PBP, it bypasses the MRSA resistance mechanism, leading to bactericidal activity against these resistant strains.
So it binds the modified target better.
Precisely. It also has some in vitro activity against enterococci and a broad gram-negative spectrum, quite similar to ceftriaxone. However, it's important to note that it is not active against AMPC or extended-spectrum lactamase-producing organisms. Ceftaroline is currently approved for the treatment of complicated skin and soft tissue infections and community-acquired pneumonia, typically at a dose of 600 milligrams infused every 12 hours. It has also been used off-label for more complicated infections like bacteremia, endocarditis, and osteomyelitis, sometimes in combination with other agents, and often at an increased dose of 600 milligrams every 8 hours. Its normal half-life is about 2.7 hours, and it's primarily excreted renally, so it requires dose adjustment in renal impairment.
The fight against resistant gram-negative infections continues. What about the new cephalosporins combined with lactamase inhibitors? What's their specific advantage?
These combinations were developed precisely to combat increasingly resistant gram-negative infections, particularly those producing tricky volactamases. These include ceftolozine tazobactam and ceftazidime avivectam, both of which are FDA approved for complicated intra-abdominal infections, complicated urinary tract infections, and hospital-acquired and ventilator-associated bacterial pneumonia. Both agents possess potent in vitro activity against gram-negative organisms, including Pseudomonas aeruginosa and AMPC and ESBL-producing Enterobacterales. This is a huge step forward against some of the most difficult pathogens.
That sounds promising. Any limitations?
Well, neither agent is active against organisms producing metallo-lactamases, a different, very dangerous class of resistance enzymes. However, ceftazidime avibactam may be an option for certain carbapenems-producing organisms, depending on the specific enzyme involved. Because they have limited activity against anaerobic pathogens, both should be combined with metronidazole when treating complicated intra-abdominal infections. Both agents have relatively short half-lives of 2-3 hours, meaning they are dosed every 8 hours, and both are primarily renally excreted, requiring dose adjustment in patients with impaired renal clearance.
And a truly fascinating new development is the cytidine-4 cephalosporin, cefiderocol. The idea of a drug literally being pumped into the bacterial cell is incredible. Can you elaborate on this unique mechanism and its implications?
Cefiderocol is indeed a unique innovation for treating resistant more lactamase-producing gram-negative organisms. Like other cephalosporins, cefiderocol works by binding to penicillin-binding proteins, inhibiting cell wall synthesis. But what makes it truly unique is its transport mechanism.
The Trojan horse approach.
Kind of, yeah. Unlike other beta-lactams that passively transport across porin channels in a bacterial cell wall, cefiderocol is actively bound by active iron transporters and then pumped into bacterial cells at a high concentration. It essentially tricks the bacteria into importing it, leveraging the bacteria's own need for iron. In addition to this active transport, cefiderocol is remarkably stable in the presence of all types of beta-lactamases, including those responsible for multi-drug resistance, such as metallo-lactamases, which is a major concern.
Wow, stable against all types.
That's the claim, and it's significant. Because of these unique characteristics, cefiderocol has potent in vitro activity against a wide range of aerobic gram-negative organisms, including highly drug-resistant Enterobacterales, Pseudomonas aeruginosa, and Acinetobacter baumannii. This makes it a potential last resort option. However, it does come with an important warning. It has been associated with increased mortality in patients with carbapenem-resistant gram-negative infections based on results from one clinical trial.
Well, that's serious.
It is. Thus, the drug label indicates that cefiderocol should be reserved for circumstances where there are limited or no alternative treatment options. It is not expected to have activity against gram-positive or anaerobic organisms. This is a powerful but carefully reserved weapon.
Let's shift our focus to the adverse effects of cephalosporins, which share some similarities and distinct differences from penicillins. What should an elite professional keep in mind?
Like penicillins, cephalosporins can elicit a variety of hypersensitivity reactions, including anaphylaxis, fever, skin rashes, nephritis, granulocytopenia, and hemolytic anemia. Patients with a documented history of penicillin anaphylaxis do have an increased risk of reacting to cephalosporins compared to those without such a history. However, the chemical nucleus of cephalosporins is sufficiently different from that of penicillin such that many individuals with a history of penicillin allergy can still tolerate cephalosporins.
So cross-reactivity isn't guaranteed.
No, and overall, the frequency of cross-allergenicity between the two groups of drugs is low, estimated at around 1%. This cross-allergenicity appears to be most common among penicillin, aminopenicillins, and early-generation cephalosporins, as they share similar R1 side chains, causing more structural overlap. Therefore, patients with a history of anaphylaxis to penicillins should not receive first- or second-generation cephalosporins. Third- and fourth-generation cephalosporins, due to less structural similarity, may be administered with caution, preferably in a monitored setting.
What about non-allergic toxicity?
Regarding toxicity, local irritation can cause pain after intramuscular injection and thrombophlebitis after intravenous injection. Renal toxicity, including interstitial nephritis and tubular necrosis, can uncommonly occur. A notable point is that certain cephalosporins contain a methyl-thiotetrazole group in their structure, which may cause hypoprothrombonemia and bleeding disorders, essentially affecting blood clotting. Historically, this group included cefamandole, cefmetazole, and cefoperazone. Currently, cefutin is the only methyl-thiotetrazole-containing agent used in the USA. This uncommon problem can often be prevented with oral vitamin K, 10 milligrams twice nightly. Drugs with this methyl-thiotetrazole ring can also cause severe disulfiram-like reactions, meaning that alcohol and alcohol-containing medications must be strictly avoided during treatment to prevent severe nausea, vomiting, and other unpleasant symptoms. This is a crucial patient education point.
Definitely important to warn patients about that alcohol interaction. #see other beta-lactam drugs. This raises an important question. How do we fight back when the bacteria develop their own defenses? That's where some of the other beta-lactam drugs come into play, specifically addressing the mechanisms of bacterial resistance. Let's delve into monobactams.
First, let's look at monobactams. These are unique drugs with a monocyclic beta-lactam ring, a single ring, unlike the fused rings of penicillins and cephalosporins. Their spectrum of activity is notably limited exclusively to aerobic gram-negative organisms, including Pseudomonas aeruginosa.
Only gram-negative.
Yes. Unlike other lactam antibiotics, they have no activity against gram-positive bacteria or anaerobes. Aztreonam is the only monobactam available in the USA. It has structural similarities to ceftazidime, and its gram-negative spectrum is also quite similar to that of the third-generation cephalosporins. Aztreonam is stable to many lactamases, but there are notable exceptions, including AMP-C lactamases and extended-spectrum melolactamases, which can still inactivate it. It penetrates well into the cerebrospinal fluid, making it useful for CNS infections. Aztreonam is typically given intravenously every 8 hours in a dose of 1 or 2 grams, providing peak serum levels of about 100 millicgml. Its half-life is 1–2 hours, but this is greatly prolonged in renal failure, requiring careful dose adjustment.
What about allergy if someone's allergic to penicillin?
That's a key advantage for Aztreonam. Penicillin-allergic patients generally tolerate it without a reaction, which is a major clinical benefit, offering a safe alternative. However, because of its structural similarity to ceftazidime, there's a theoretical potential for cross-reactivity if a patient has a documented severe allergy to ceftazidime. Occasional skin rashes and elevations of serum aminotransferases can occur, but major toxicity is uncommon. Its primary clinical use is to treat serious infections like pneumonia, meningitis, and sepsis caused by susceptible gram-negative pathogens in patients with a history of penicillin anaphylaxis, where other beta-lactams might be contraindicated.
So if bacteria are getting good at making beta-lactamases, how do we directly combat those enzymes? This is where beta-lactamase inhibitors come in, right? What are the key players here, and how do they help us turn the tide?
You've hit on a crucial strategy in the arms race, host. These inhibitors, clavulanic acid, sulbactam, tazobactam, avibactam, vaborbactam, and relebactam, are designed to directly combat bacterial enzymes that destroy our antibiotics. The traditional inhibitors, clavulanic acid, sulbactam, and tazobactam, resemble lactam molecules in structure, but they themselves have very weak antibacterial action. Their primary function is to act as potent inhibitors of many, but not all, bacterial lactamases.
So they sacrifice themselves almost.
In a way, yes. They bind to the enzyme. By doing so, they protect hydrolyzable penicillins from inactivation by these enzymes, allowing the penicillin to do its job. These traditional inhibitors are most active against Ambler class A lactamases, particularly plasmid-encoded tembo-lactamases, which are commonly found in Staphylococcus aureus, Haemophilus influenza, Neisseria gonorrhoeae, Salmonella, Shigella, Escherichia coli, and Klebsiella pneumonia. However, they are not good inhibitors of class C lactamases, which are typically chromosomally encoded and may be inducible, produced by organisms like Enterobacter species, Citrobacter species, Serratia marcescens, and Pseudomonas aeruginosa. They do, however, inhibit the chromosomal lactamases of Bacteroides fragilis and Moraxella cataralis, which is clinically useful, and the newer inhibitors. What's fascinating are the novel non-beta-lactam lactamase inhibitors like avibactam, vobribactam, and relebactam. These agents represent a newer generation active against both ambler class A and ambler class C lactamases, a significant improvement. Avibactam specifically also has activity against some ambler class D lactamases, such as OXA48, which can confer carbapenem resistance and has been identified in highly resistant Klebsiella pneumonia isolates. Relebactam, which is approved for use in a fixed-dose combination with the carbapenem imipenem cilastatin, is expected to have similar activity to avibactam.
And these inhibitors are always paired with an antibiotic.
Yes, these beta-lactamase inhibitors are only available in fixed combinations with specific penicillins and cephalosporins. The addition of an inhibitor extends the spectrum of its companion beta-lactam, but only if the original inactivity against a particular organism was due to its destruction by a beta-lactamase, and if the inhibitor is active against that specific beta-lactamase.
Okay, that's a critical point.
It is. For example, ampicillin sulbactam is active against vlactamose-producing S. aureus in H. influenza, but it's not active against Serratia because Serratia produces a monolactamase that sulbactam doesn't inhibit. Similarly, if a strain of Pseudomonas aeruginosa is resistant to piperacillin, it will also be resistant to piperacillin tazobactam because tazobactam doesn't inhibit the chromosomal phthalactamase produced by P. aeruginosa. These lactam-flutamycin inhibitor combinations are frequently used as empiric therapy for infections with a wide range of potential pathogens in both immunocompromised and immunocompetent patients. Simplifying treatment choices, though precision in understanding their limitations is vital for elite professionals. Adjustments for renal insufficiency are made based on the elactam component, not the inhibitor.
Carbapenems, often seen as the big guns. Let's explore their unique strengths. What makes them so potent, and what are their limitations in this escalating arms race?
The carbapenems are another class structurally related to other lectin antibiotics, and they are indeed considered big guns due to their very broad spectrum of activity. Ertapenem, imipenem, and meropenem are currently licensed for use in the USA. Imipenem, the first drug of this class, boasts a wide spectrum with good activity against most gram-negative rods, including Pseudomonas aeruginosa as well as gram-positive organisms and anaerobes. It is notably resistant to most beta-lactamases, including AMP-C and many ESBLs, but not to serine carbapenemases or metallo-lactamases, which are emerging threats. Resistant organisms include Enterococcus faecium, methicillin-resistant Staphylococci, Clostridioides difficile, Burkholderia cepacia, and Stenotrophomonas maltophilia. A specific detail about imipenem for mastery. It is inactivated by dehydropeptidases in renal tubules. Consequently, for clinical use, it is always administered together with cilastatin, an inhibitor of this renal dehydropeptidase, to prevent its breakdown and ensure sufficient drug reaches the target.
Ah, so cilastatin protects imipenem.
Exactly. Doripenem and meropenem are similar to imipenem, but they have slightly greater activity against gram-negative aerobes and slightly less activity against gram-positives. A key difference is that they are not significantly degraded by renal dehydropeptidase and therefore do not require an inhibitor like cilastatin, simplifying administration. Despite their broad-spectrum activity, carbapenems can still be degraded by highly resistant organisms, such as carbapenemase-producing gram-negative pathogens, often referred to as CRE, or carbapenem-resistant Enterobacterales.
So even the big guns face resistance.
They do. As a result, novel combination products have been developed. Meropenem vaborbactam was the first to gain FDA approval, and it can restore meropenem's activity against certain lactamase producers. A fixed-dose combination of imipenem and relebactam also retains activity against these highly drug-resistant organisms, showing our continued innovation in this fight. Unlike the other carbapenems, ertapenem has a distinct activity profile in that it does not have appreciable activity against Pseudomonas aeruginosa and Acinetobacter species, making it less suitable for certain severe hospital-acquired infections, but excellent for others. It is also not degraded by renal dehydropeptidase.
How well do these penetrate tissues, especially the CNS?
Regarding their pharmacokinetics, carbapenems generally penetrate body tissues and fluids well, including the cerebrospinal fluid for all but ertapenem. Data is still limited regarding CNS penetration of meropenem vaborbactam. All carbapenems are cleared renally, meaning their dose must be reduced in patients with renal insufficiency. The usual dosage of imipenem is 0.25–0.5 grams, given intravenously every 6 to 8 hours, with a half-life of 1 hour. Meropenem's usual adult dosage is 0.5 to 1 gram intravenously every 8 hours, though for meningitis it's increased to 2 grams every 8 hours. When meropenem is combined with vaborbactam, the usual dose is 4 grams, 2 grams meropenem and 2 grams vaborbactam, administered as a 3-hour infusion every 8 hours. Doripenem's usual adult dosage is 0.5 grams administered as a 1 or 4-hour infusion every 8 hours. Ertapenem stands out with the longest half-life in the class at 4 hours, which allows for convenient once-daily dosing of 1 gram intravenously or intramuscularly. If given intramuscularly, ertapenem can be irritating, so it can be mixed with 1% lidocaine for administration by this route.
Where are carbapenems most commonly used?
In terms of clinical uses, a carbapenem is indicated for infections caused by susceptible organisms that are resistant to other available drugs, for example, Pseudomonas aeruginosa. They are highly effective for mixed aerobic and anaerobic infections. Carbapenems are also active against many penicillin non-susceptible strains of pneumococci. They are particularly highly active and considered the treatment of choice for Enterobacter infections because they are resistant to destruction by the Beta-Lactamase produced by these organisms.
So they overcome that specific resistance.
Yes. Clinical experience and data suggest that carbapenems are also the treatment of choice for serious infections caused by ESBL-producing gram-negative bacteria. It's crucial to remember that ertapenem is not sufficiently active against Pseudomonas aeruginosa and should not be used to treat infections caused by this organism. Imipenem, meropenem, or doripenem, when available, sometimes with or without an aminoglycoside, may be effective treatments for patients with febrile neutropenia, where a broad-spectrum empiric agent is often needed to cover a wide range of potential pathogens.
What about their side effects? Any major concerns?
For adverse effects, the most common with carbapenems, which tend to be more frequent with imipenem, include nausea, vomiting, diarrhea, skin rashes, and reactions at the infusion sites. A serious concern for elite professionals. Excessive levels of imipenem in patients with renal failure can lead to seizures. Meropenem and ertapenem are much less likely to cause seizures than imipenem, which is a significant safety advantage.
That's a big difference.
It is. Patients allergic to penicillins may also be allergic to carbapenems, but the incidence of cross-reactivity is thought to be low, less than 1%. Looking to the future, tebipenem pivoxyl hydrobromide is an orally bioavailable carbapenem currently under study in clinical trials. If approved in the USA, it would be the first oral option in the carbapenem class. Due to its broad gram-negative spectrum, it would likely play a significant role in treating urinary tract infections caused by organisms resistant to other oral antibiotics. It may also prove useful in treating infections due to drug-resistant Shigella and typhoidal salmonella.
An oral carbapenem would be quite something. Moving beyond the Lactam family, we find other crucial antibiotics targeting the cell wall and membrane. Expert, how do these drugs fit into our ongoing battle and what makes them unique?
They are absolutely vital, providing alternative strategies when beta-lactams might not be effective due to resistance or allergy. These drugs have unique mechanisms, making them indispensable.
Let's start with vancomycin. This is a drug many people have heard of, often mentioned as a last resort for certain infections. What makes it so unique, and what's its particular niche?
Vancomycin, originally isolated from Amycloatopsis orientalis, is indeed incredibly important. Its spectrum of activity is primarily against gram-positive bacteria. This specificity is due to its large molecular weight and its inability to penetrate the outer membrane of gram-negative bacteria, effectively blocking its entry. The intravenous product of vancomycin is water-soluble and remains stable for 14 days in the refrigerator after reconstitution, which is useful for hospital pharmacies.
How does it work differently from the beta-lactams?
Its mechanism of action is distinct from beta-lactams, which is why it's so valuable against resistant strains. Vancomycin inhibits bacterial cell wall synthesis, but it does so by binding firmly to the DALA terminus of the nascent peptidoglycan pentapeptide. This binding specifically inhibits the transglycosylase enzyme, which prevents further elongation of the peptidoglycan chains, and also inhibits cross-linking. The result is a weakened peptidoglycan layer, making the cell susceptible to lysis. Vancomycin also appears to damage the bacterial cell membrane, which further contributes to its antibacterial effect. It's a multi-pronged attack on the bacterial fortress.
So it targets a different part of the cell wall construction. How do bacteria develop resistance to vancomycin then?
This is a fascinating story of bacterial adaptation. In Enterococci, resistance to vancomycin, known as VRE, is due to a clever modification of the dala-dindala binding site of the peptidoglycan building block. Instead of dala-dala, the terminal dala is replaced by dalactate.
Just changing one molecule?
A small change with a huge impact. This seemingly small chemical change causes the loss of a critical hydrogen bond that is essential for the high-affinity binding of vancomycin to its target, thereby resulting in a complete loss of activity. It's like the lock has changed its internal structure just enough so that the key no longer fits at all. This mechanism has also been observed in rare vancomycin-resistant Staphylococcus aureus, RSA strains, which acquire these enterococcal resistance determinants, making them extremely difficult to treat. The underlying mechanism for reduced vancomycin susceptibility in vancomycin intermediate S. aureus, VISA, where the MIC is 4-8 millicg/ml, is not yet fully known. However, these strains have altered cell wall metabolism, which leads to a significantly thickened cell wall.
A thicker wall, how does that help them?
This thicker cell wall has an increased number of dala-dala residues that act as dead-end binding sites, essentially sequestering the vancomycin within the outer layers of the cell wall and preventing it from reaching its true site of action where it needs to bind to be effective. It's a very clever defensive maneuver.
Wow. And how active is vancomycin generally?
In terms of its antibacterial activity, vancomycin is bactericidal for gram-positive bacteria at concentrations typically ranging from 0.5–10 millicd/ml. Most pathogenic staphylococci, including those that produce the lactamase and even those resistant to nafcillin and methicillin, MRSA, are killed by 2 millicg/ml or less. However, it's important to note that vancomycin kills staphylococci relatively slowly and only if the cells are actively dividing. The rate of kill is generally less than that of penicillins, both in vitro and in vivo.
Slower kill rate, that's interesting.
Vancomycin shows in vitro synergism with gentamicin and streptomycin against Enterococcus faecium and Enterococcus faecalis strains that do not exhibit high levels of aminoglycoside resistance, making them useful combinations. It is also active against many gram-positive anaerobes, including Clostridioides difficile.
How is vancomycin handled by the body? You mentioned it's mainly for gram-positives.
For pharmacokinetics, vancomycin is poorly absorbed from the intestinal tract, so it is administered orally only for the local treatment of colitis caused by Clostridioides difficile, where its action is localized to the gut lumen.
So oral is just for C, diff in the gut.
Exactly. For systemic infections, parenteral doses must be administered intravenously. A 1-hour intravenous infusion of 1 gram typically produces blood levels of 15–30 millicg/ml for 1–2 hours. The drug is widely distributed throughout the body, including adipose tissue. If there is meningeal inflammation, as in meningitis, cerebrospinal fluid levels can reach 7–30% of simultaneous serum concentrations, which is usually sufficient for treatment. A significant portion, 90% of the drug, is excreted by glomerular filtration. In the presence of renal insufficiency, striking accumulation of the drug can occur. In functionally ineffective patients, for example, the half-life of vancomycin can be as long as 6–10 days. A significant amount of vancomycin is removed during a standard hemodialysis run using a high-flux membrane, requiring careful dosing around dialysis schedule.
So monitoring levels is crucial, especially with kidney issues?
Absolutely. Traditionally, clinicians have relied on therapeutic drug monitoring by monitoring vancomycin's trough levels, which is the lowest concentration of the drug in the blood just before the next dose. However, newer guidelines suggest that the pharmacokinetic target associated with clinical efficacy is an area under the curve to minimum inhibitory concentration ratio, AUC-mic ratio, of 400 mJ/HL. This has been difficult to measure in routine clinical practice, but more tools like online calculators or pharmacokinetic software have become available to help. These guidelines now suggest that AUC monitoring may be preferred to optimize the time at appropriate drug targets while simultaneously decreasing the likelihood of developing nephrotoxicity or kidney damage.
So a shift from troughs to AUC-mic.
Yes, it's a significant shift in how vancomycin therapy is managed by elite professionals, aiming for both efficacy and safety.
Where is vancomycin primarily used clinically?
In terms of clinical uses, important indications for parenteral vancomycin include bloodstream infections and endocarditis caused by methicillin-resistant staphylococci, MRSA. However, it's important to note that vancomycin is not as effective as an anti-staphylococcal penicillin for treating serious infections like endocarditis caused by methicillin-susceptible strains. Targeted beta-lactams are often superior there. Vancomycin, often in combination with gentamicin, is an alternative regimen for treating enterococcal endocarditis in patients with a serious penicillin allergy. Vancomycin, usually in combination with cefotaxime, ceftriaxone, or rifampin, is also recommended for the treatment of meningitis suspected or known to be caused by a penicillin-resistant strain of pneumococcus, providing crucial coverage where other first-line agents may fail.
How is it typically dosed?
The recommended dosage in a patient with normal renal function is 30-60 millirichloroJ in 2 or 3 divided doses. The traditional dosing regimen in adults with normal renal function, often 1 gram every 12 hours, which is around 30 millirichloroJ, is often insufficient to achieve the trough concentrations or the preferred AUC-LNEC-MIC ratio recommended for serious infections. Therefore, for serious infections, a starting dose of 45-60 millirichloroJ should be considered, with subsequent titration of the dose to achieve trough levels of 15-20 milligml or an AUC-MIC ratio of 400-600 milligml.
Higher doses needed for serious cases, then?
Yeah. Often, yes. For children, the dosage is typically 40-60 milligram per MD in 3 or 4 divided doses. Since vancomycin clearance is directly proportional to creatinine clearance, the dosage is reduced accordingly in patients with renal insufficiency. For patients receiving hemodialysis, a common dosing regimen is a 1-gram loading dose, followed by 500 milligrams after each dialysis session, though this is adjusted based on serum trough concentrations. Oral vancomycin, typically 0.125-0.5 grams every 6 hours, is used exclusively to treat colitis caused by Clostridioides difficile, though recent guidelines express a preference for fidaxomicin due to its association with lower rates of relapse.
And the side effects. We hear about red man syndrome.
Let's discuss adverse reactions to parenteral vancomycin. These are encountered fairly frequently, though most reactions are relatively minor and reversible. Vancomycin can be irritating to tissues, often resulting in phlebitis or inflammation of the vein at the injection site. Chills and fever may also occur. Ototoxicity, or damage to the inner ear leading to hearing loss or balance issues, is rare, but can occur, minimized by careful monitoring of peak serum concentrations below 60 millicgml. Nephrotoxicity, or kidney damage, is still regularly encountered even with current preparations, especially when high trough levels are achieved or when vancomycin is co-administered with other ototoxic or nephrotoxic drugs, such as aminoglycosides. Among the more common reactions is infusion-related flushing, often referred to as red man syndrome. This is caused by the release of histamine. It can largely be prevented by simply prolonging the infusion period to 1 to 2 hours, which is the preferred method, or by pre-treating the patient with an antihistamine like diphenhydramine.
What about teicoplanin? Is it similar to vancomycin?
Teicoplanin is another glycopeptide antibiotic, very similar to vancomycin in its mechanism of action and antibacterial spectrum. However, unlike vancomycin, teicoplanin can be given intramuscularly as well as intravenously, offering more flexibility. It also boasts a significantly longer half-life, ranging from 45-70 hours, which conveniently permits once-daily dosing. This drug is available in Europe, but it has not been approved for use in the USA.
And telavancin, a newer relative of vancomycin. I understand it has a dual mechanism of action. Can you explain that and its specific applications and warnings?
Telavancin is a semi-synthetic lipoglycopeptide derived from vancomycin, active against gram-positive bacteria, including some strains that have reduced susceptibility to vancomycin. What makes telavancin interesting is its dual mechanism of action.
2 ways to attack.
Exactly. Like vancomycin, it inhibits cell wall synthesis by binding to the ala terminus of peptidoglycan in the growing cell wall. But in addition to that, it also increases membrane permeability and disrupts the bacterial cell membrane potential, essentially poking holes in the bacterial membrane. Telavancin has a half-life of approximately 8 hours, sporting once-daily intravenous dosing. It's approved for the treatment of complicated skin and soft tissue infections and hospital-acquired pneumonia, typically at a dose of 10 milligkg intravenously daily. Unlike vancomycin therapy, monitoring of serum telavancin levels is generally not required. However, it comes with boxed warnings because in clinical trials, telavancin was associated with substantial nephrotoxicity and a concern for increased mortality in patients with renal impairment.
So significant kidney risk.
Yes, and it's also potentially teratogenic, meaning it can cause birth defects, so its administration to pregnant women must be avoided. These warnings are critical for clinical decision-making.
Lastly, in the glycopeptide family, dalbavancin and oritavancin. What makes these particularly innovative with their extremely long half-lives?
Dalbavancin and oritavancin are both semi-synthetic lipoglycopeptides derived from teicoplanin. Like vancomycin and teicoplanin, both inhibit cell wall synthesis through the same core mechanism. However, oritavancin has additional mechanisms of action, including disruption of cell membrane permeability and inhibition of RNA synthesis, giving it a broader attack. Compared with vancomycin, both agents have lower MICs against many gram-positive bacteria, including methicillin-resistant S. aureus, MRSA, and vancomycin intermediate S. aureus, VIM.
Better activity against MRSA.
Lower MICs, yes. Dalbavancin is not active against most strains of vancomycin-resistant enterococci, VRE, but oritavancin does have in vitro VRE activity, though its clinical utility in treating VRE infections remains unclear. A standout feature of both these agents is their extremely long half-lives, greater than 10 days, which allows for incredibly convenient once-weekly intravenous administration, a huge benefit for outpatient treatment and patient adherence.
Once a week.
It's a major advantage. Both dalbavancin and oritavancin have been approved for the treatment of skin and soft tissue infections. Limited clinical data also support the off-label use of dalbavancin for uncomplicated catheter-associated bloodstream infections. Dalbavancin was originally approved as a 2-dose, once-weekly intravenous regimen, but a subsequent Phase 3 study showed a single 1,500 milligram intravenous dose was non-inferior. This led to updated labeling, making both dalbavancin and oritavancin appropriate for single-dose treatments for complicated skin and soft tissue infections. Dalbavancin has even been studied for the treatment of osteomyelitis, with one trial showing a 97% cure rate in patients who received 2 weekly 1,500 milligram intravenous doses, highlighting its potential in chronic infections. A practical difference between the two is infusion time. Dalbavancin can be administered over just 30 minutes, while oritavancin must be infused over 3 hours. Neither requires dose adjustment in mild to moderate renal or hepatic impairment, and importantly, neither is removed by dialysis, which is a key consideration for patients with kidney disease. #BB, other cell wall or membrane active agents.
Beyond the major Lactam and glycopeptide families, there are other critical antibiotics that target the bacterial cell wall or membrane with unique mechanisms.
Let's delve into daptomycin. What makes this cyclic lipopeptide so distinct?
Daptomycin is a novel cyclic lipopeptide that is a fermentation product of Streptomyces roseosporus. Its spectrum of activity is quite similar to vancomycin, except it may be active against vancomycin-resistant strains of enterococci and S. aureus, making it a vital alternative.
So it covers VRE and VRSA potentially?
Potentially, yes. In vitro, it also demonstrates more rapid bactericidal activity than vancomycin. The precise mechanism of action for daptomycin isn't fully understood, but it's known to bind to the bacterial cell membrane via calcium-dependent insertion of its lipid tail. This binding leads to a rapid depolarization of the cell membrane with potassium efflux and ultimately rapid cell death. Interestingly, cell lysis does not occur with daptomycin, which is a key mechanistic difference from lactams.
Depolarizes the membrane. Different approach. Very different. Daptomycin is cleared renally. The approved doses are 4 mg/kg per dose for skin and soft tissue infections and 6 mg per dose for bacteremia and endocarditis, given once daily in patients with normal renal function or every other day in patients with creatinine clearance less than 30 millimolin. For serious infections, many experts actually recommend using higher doses, typically 8-10 mg/kg. These higher doses appear to be safe and well tolerated, although robust evidence supporting increased efficacy at these higher doses is still lacking. In clinical trials, daptomycin was found to be non-inferior in efficacy to vancomycin.
What are the downsides or specific warnings for daptomycin?
Now, some important adverse effects and limitations for daptomycin for elite professionals. It can cause myopathy or muscle damage, so creatine phosphokinase levels should be monitored weekly. A critical limitation is that pulmonary surfactant found in the lungs antagonizes daptomycin, meaning it inactivates it. Therefore, daptomycin should not be used to treat pneumonia.
Can it be used for pneumonia? That's huge.
Absolutely critical to remember. It can also cause an allergic pneumonitis or lung inflammation in patients receiving prolonged therapy, typically beyond 2 weeks. Treatment failures have been reported in association with an increase in daptomycin MIC during therapy, indicating bacteria can develop resistance. Daptomycin is often an effective alternative to vancomycin, sometimes used as monotherapy, or it may be combined with a second antibacterial agent, such as a Beta-Lactam.
Next, fosfomycin. This drug is truly unique in its mechanism. How does it manage to inhibit cell wall synthesis at such an early stage?
Fosfomycin is truly unique. It's an analog of phosphenylpyruvate and structurally unrelated to any other antimicrobial agent. It inhibits a very early stage of bacterial cell wall synthesis. Specifically, it inhibits the cytoplasmic enzyme pyruvate transferase by covalently binding to its active site, thereby blocking the addition of phosphenylpyruvate to UDP-N-acetylglucosamine. This reaction is the very first step in the formation of UDP-N-acetylmuramic acid, which is the precursor of N-acetylmuramic acid, an essential component found only in bacterial cell walls.
So it hits way upstream in the process.
Exactly. It hits the bacteria right at the foundational steps of cell wall construction. The drug is transported into the bacterial cell by glycerphosphate or glucose 6-phosphate transport systems, and resistance can emerge due to inadequate transport of the drug into the cell. Fosfomycin is active against both gram-positive and gram-negative organisms at concentrations usually greater than or equal to 125 millicgml. Susceptibility tests should be performed in growth medium supplemented with glucose 6-phosphate to minimize false positive indications of resistance. Interestingly, in vitro synergism occurs when fosfomycin is combined with lactam antibiotics, aminoglycosides, or fluoroquinolones. Fosfomycin trametamol is available in both oral and parenteral formulations, but currently only the oral preparation is approved for use in the USA.
How's it used, being only oral in the U.S.?
Oral bioavailability is approximately 40%. Peak serum concentrations reach about 10 millicgml and 30 millicgml following a 2-gram or 4-gram oral dose, respectively. Its half-life is approximately 4 hours, and the active drug is primarily excreted by the kidney, achieving high urinary concentrations that exceed MICs for most urinary tract pathogens. Fosfomycin is approved for use as a single 3-gram dose for the treatment of uncomplicated lower urinary tract infections, UTIs, in women. While limited case report data have suggested efficacy in males with UTI and prostatitis, in these cases, a 3-gram dose has been given every 3 days for 9 days for UTI or 21 days for prostatitis. There is a notable lack of data to support using oral fosfomycin to treat pyelonephritis, which is a more serious kidney infection. The drug appears to be safe for use in pregnancy.
Mostly for uncomplicated UTIs, then. Then there's bacitracin, which I mostly associate with topical ointments. Why is it only used topically, and what's its mechanism?
Bacitracin, a cyclic peptide mixture first obtained from the Tracy strain of Bacillus subtilis in 1943, is active against gram-positive microorganisms. Bacitracin inhibits cell wall formation by interfering with the dephosphorylation step in the cycling of the lipid carrier that transfers peptidoglycan subunits to the growing cell wall.
Another unique cell wall target.
Yes. There is no known cross-resistance between bacitracin and other antimicrobial drugs. However, bacitracin is highly nephrotoxic when administered systemically, which is why it is only used topically. It is poorly absorbed when applied topically, resulting in localized antibacterial activity, making it safe for surface use. Bacitracin, typically 500 units per gram in an ointment base, often combined with polymyxin or neomycin for broader coverage, is used for the treatment of infections due to mixed bacterial flora in surface lesions of the skin or on mucous membranes. It is commonly associated with hypersensitivity reactions and, importantly, should not be applied to wounds for the sole purpose of preventing infection, as it can actually sensitize the patient to future reactions.
Good point about not just using it preventatively on wounds. Finally, cycloserine. This is a drug with a very specific, almost exclusive use. Can you tell us about its unique mechanism and its primary application?
Cycloserine, an antibiotic produced by Streptomyces orchidaceus, is water-soluble but very unstable at acid pH. Cycloserine inhibits many gram-positive and gram-negative organisms, but it is used almost exclusively to treat tuberculosis caused by strains of Mycobacterium tuberculosis resistant to first-line agents.
So it's a TB drug, mainly for resistant cases.
Primarily, its mechanism of action is unique. Cycloserine is a structural analog of dealanine. It inhibits the incorporation of dealanine into the peptidoglycan pentapeptide by inhibiting 2 key enzymes, alanine racemase, which converts alanine to dealanine and alanyl-dealanine ligase. This disrupts the very early building blocks of the mycobacterial cell wall, which is unique. After ingestion of 0.25 grams of cycloserine, blood levels can reach 20-30 millicgml, which is sufficient to inhibit many strains of mycobacteria and gram-negative bacteria. The drug is widely distributed in tissues, and most of it is excreted in active form into the urine. The typical dosage for treating tuberculosis is 0.5 to 1 gram per day, administered in 2 or 3 divided doses.
Are there major side effects with this one?
Now, a very important point about cycloserine for any professional. It causes serious dose-related central nervous system toxicity, which can manifest as headaches, tremors, acute psychosis, and even convulsions.
CNS toxicity.
Yeah,
That's it.
it can be. These severe effects can usually be avoided by carefully maintaining oral dosages below 0.75 grams per day. This requires very careful monitoring in patients. #tag outro.
So what does all this mean for you, our curious listener? We've journeyed through the complex and fascinating world of cell wall and membrane-active antibiotics, from the pioneering penicillins that sparked a revolution to the advanced carbapenems and the unique glycopeptides that act as crucial last resorts. We've explored their intricate mechanisms, their specific uses, and the constant evolving threat of resistance that challenges every step forward. Understanding these fundamentals, these battles at the microscopic level, truly equips you to appreciate the complexity of modern medicine and the daily ingenuity required to fight against evolving pathogens. You've just gained a level of mastery that few outside the immediate professional field grasp.
If we connect this to the bigger picture, the story of antimicrobials is far from over. What we've explored today, from the earliest discoveries to the latest innovations, is a testament to human ingenuity. But it also profoundly underscores that the battle against resistance is ongoing. It requires continuous vigilance, relentless research into new mechanisms and drugs, and critically responsible use by everyone. Antimicrobial stewardship isn't just a buzzword, it's a critical global health imperative that affects all of us.
It really is a global challenge.
Absolutely. As bacteria continue to evolve, what new battlegrounds for resistance will emerge next, and how will human ingenuity rise to meet them? How will you contribute to this ongoing challenge? Simply by being more informed and understanding the profound impact of these microscopic interactions on our lives and in the choices we make.
Thank you for joining us on the Deep Dive. Keep that curiosity alive, and we look forward to exploring more fascinating topics with you next time.